multi-center examination of the etiology of recurrent veins after thermal ablation, either with RF or laser. And these are the authors on here. All these authors are former vascular general surgeons who now do only venous surgery. There were 7 centers, all board certified. All patients seen in 2010 were, for the diagnosis and treatment of venous disease, were enrolled in this study. Those with previous history of thermal ablation of the GSV, SSV, AAGSV were considered candidates. The total was 164 patients. 83% of these patients had their initial treatment by the same participating surgeon, which I think gives a lot of credibility and a lot of durability of what's going on. This is a specifically designed study tool. You can't see it here very well. There are 3 different pages. Some of this was formed from the REVATA study, and some is unique to this study. The study tool was given, the results were given numerical values, which you'll see in a minute. Then using the SPSS program for statistical analysis, we did cross tabulations in 15 different categories. Some of the categories having as much as 8 subsets. There's a huge amount of tabulation done. And thank God my son-in-law is a statistician with the VA Medical Center. So not only were the REVATA studies reviewed and profiled, but comparison was always also made between the results of the REVATA study. And this just shows you a sample of what we did. This is a repeat ultrasound of the greater saphenous vein when the patient showed up at the clinic in 2010. We reevaluated for complaints of recurrent varices for some reason. And you can see here there was saphenous recanalization in 13 patients, total recanalization, which accounted for almost 8% of the patients. As we go down here, we see saphenous partial, associated with perforators, associated with branching flow, new saphenous insufficiency and unablated segments, and then saphenous insufficiency and unablated segments associated with perforator. So all these categories in the saphenous vein were examined. And you also see that there were 92 ablated saphenous veins. So that meant that of all the patients that came back in, 92 of these patients still had an ablated saphenous vein. Oh, sorry. So after we did this, we also repeated an ultrasound of the SSV. There were 5 primary treatments of the SSV without GSV. There were 40 secondary treatments of the SSV, including intravenous ablation at the same time with the GSV. So this is a whole new subgroup here. And this is a repeat ultrasound, which we'll talk about a little bit, the results. There was new reflux in 27 patients. 40 patients out of the 45 remain ablated. 3 patients out of this group had RF. 2 of the partial recanalizations were laser. There were normal ultrasound examinations in 92 patients. We then looked at the repeat ultrasounds of the AAGSV, and this is kind of a surprising finding, at least to me at the time. But there were 2 recanalizations of the AAGSV. There was a partial recanalization in 2 patients, but there was new reflux in 40 patients. That meant that of all the patients that came back in for this treatment in 2010 that had a pre-thermal ablation of the greater saphenous vein, or the short saphenous vein, small saphenous vein, actually had new reflux in the AAGSV causing symptoms, either varicosities. For the most part, AAGSV are varicosities only, but they can also be other symptoms. The median time to reoccurrence for this study group is 3 years. You can see here the distribution. There were a few less than 6 months. They may or may not have been missed in the prior treatment ultrasound. In the results, there were RF was used in 33 patients. That was from 1 center alone. The rest of the 6 centers used only laser in different wavelengths, which we'll talk about in a minute. But there were 45, as mentioned before, secondary ablations of the SSV, which forms a new subgroup that's very important, I think makes very important points that we'll discuss. There were 10 secondary ablations of the AAGSV, median age 51 to 60, 83% were women, history of DVT in only 5% of the patients. Deep venous insufficiency. In a REVATA study, we had 17 patients with documented insufficiency of the either femoral popliteal or combination. In the REVATA study, in 2006 by Perrin and Nikos, 27% of the patients had DVI. Now, it was statistically significant between the studies. The difference, however, Cross-tabulation between the presence of DVI in all categories revealed no statistical significance whatsoever, which means DVI made no difference in the progression of anything. Presence of perforators. And this is kind of uncanny in that the presence of perforators almost parallels that within the REVATA study. 77% of patients that presented for reevaluation of symptomatic recurrent disease in 2010 had perforators. They may or may not be pathologic. And as we go on, we'll show you that only 56% of the perforators were pathologic. They can be associated with actually recurrent venous insufficiency of the saphenous vein, new small saphenous vein insufficiency, isolated varicoses or ulcer. The perforators were, as mentioned before, similar between a REVATA and a REVATA study. Perforators were associated with greater saphenous vein recannulation. Now, it was significant statistically. What's even more, when you do a pairwise comparison between the two perforators, the calf and the thigh perforator, the probability of recannulation was 3 times more likely if you had a thigh perforator than if you didn't. But also note that thermal ablation in this series did not include the region, for the most part, of the paratibial perforators, the old Shermans and Boyds, which we'll talk about in a minute. Neovascularity, 10% prevalence in the REVATA study, 24% in the REVATA study, higher in other studies, up to 60%, as mentioned before, in some studies that show neovascularity at 5 to 20 years. Neovascularity was statistically higher in the REVATA study. What's really interesting about the REVATA study is that the location of neovascularity was not in the groin, but in the saphenous sheath distal to the groin, usually at least 4 to 5 centimeters distal, and many times in the mid-thigh area. This is the cross-tabulation done with the greater saphenous vein. And what we did here is we took the method of treatment, RF, laser 940, 810, 1320, other laser. We grouped 980 and 1470 together because the numbers are so small. And we didn't want to mess up the other results. So they really don't play much of a significant part in the evaluation. The 940, 810, and 1320 do because the numbers were sufficient. When we did this cross-tabulation, we see saphenous recannulation total of 5 in the RF, 0 in the 940, and 5 in the 810. There's also partial recannulation or recannulation associated with perforators and branch inflow. All these were cross-tabulated for further analysis. So there were 47 patients in the REVATA study. 29% had partial or total recannulation. 23 patients had new saphenous insufficiency in an unablated segment, usually below the knee. 43% of the patients in the REVATA study then had some type of saphenous insufficiency. In the REVATA study, insufficiency at the groin was associated with a 47% incidence. REVATA study, less than 10% incidence of insufficiency in the groin region. In the REVATA study, there was persistent reflux in the above knee greater saphenous vein, 39%, and reflux in the below the knee, and 30%. So new saphenous insufficiency was usually associated with reflux into a previously unablated saphenous vein below the knee. In the REVATA group, there was less chance for technical failures when compared to the REVATA group. With the 940, 91% of originally treated GSVs remained ablated, 100% of the originally treated GSVs remained ablated with 1320. The average joules per centimeter in the 940 was 80, and the 1320 is 100. In the 810 laser, 3 of the failures was recannulation associated with less than 60 joules per centimeter. When we did a two-way contingency table analysis comparing RF to laser, and I write down here the majority of these RFs were older devices, we'll have to see how the new ones do. There was 7.2 times more likely to be cannulized with the 940, 2 times more likely to be cannulized with an 8 using a RF compared to an 810, and the use of RF was 10 times more likely to be cannulized than with the 1320. Okay, so the probability when comparing lasers, we'll go through this rapidly. The probability was 4.2 times likely for recannulization with 810 compared to 940. 1.9 times more likely 810 compared to 1320 due to the smaller numbers in 1320 group. The small saphenous vein, new reflux occurred in 16%. The subgroup of secondary SSV, 95% remained ablated. This compares to Robbie's group. And the REVATA subgroup that was 90, as we mentioned before, 95% continued ablation of the saphenous vein up to 8 years after treatment. In the AAGSV, 40 patients, 24% new AAGSV insufficiencies, and we talk about this in the paper about the flow differential. The conclusion, majority of perforators are associated with perforating veins. They can be directly or indirectly associated. New AAGSV or SSV response is insufficiency, 40%. In this study, laser ablation of the SSG was significantly superior to RF. Saphenous vein recanalization can be avoided by standard protocol, routine post-op exams, and probably beginning thermal ablations at the mid-calf level. And the probability, as you know, the greatest probability is infinity -1. And when we get more statistical studies, we can probably show that the number of recurrent veins after thermal ablation will be in the range of 25 to 35% less than the surgery. Thank you.